Good morning, students. Welcome to R.A.T.S in Pathology. This is a case scenario, and I hope you will be able to follow it. A 12-year-old boy presented with fever, oliguria, and cola-colored urine. He had a history of sore throat 3 weeks back. What is your probable diagnosis? Describe the etiopathogenesis. What are the relevant investigations? The differential diagnosis, and the diagram for this condition. The breakup in the marks is given below. So the diagnosis is obviously a post-streptococcal glomerulonephritis, which can be an essay, a short note, an MCQ, as well as a frequently asked viva voce question. This is a clinical picture of the condition. I am finding the bacteria in strands, the group A beta hemolytic streptococci, because of which a patient can develop either a pharyngitis or a tonsillitis, or in the skin there can be a lesion such as an impetigo. And after a period of about 1 to 2 weeks in the first case, 3 to 6 in the second, there can be the various manifestations such as hematuria, hypertension, and a periorbital edema. So there can be a hematuria, as you see a cola-colored urine. There can be some amount of proteinuria also. This is a picture that we shall and will remember. It is a little complex. I shall be slow and deliberate in explaining it. And this will be repeated any number of times. This is a tuft of capillary that we are seeing in the glomerulus. And there is a central region called the mesangium that is supporting it. And these in turn are the capillaries. The strange thing about a glomerular capillary is it has got a lining on the inside as well as outside. So there is an inner lining or the endothelium and an outer lining or an epithelium. So these will be the tuft of capillaries. The basic mechanism of any glomerular injury can be immunological. And when I say immunology, it is antigen, antibody, or an antigen-antibody complex. And they are basically divided into circulating immune complex. So here I am finding the dots are there, which are the antigens, and the Y's, which are the antibodies. So these form complexes and they get deposited in the subepithelial or the endothelial regions. This is one. That is a circulating immune complex. And on another, there can be antiglomerular basement membrane antibody. So the antigens are all linearly located along the basement membrane, and these are the antibodies which get attached to it, and I find a linear deposit. It is an antiglomerular basement membrane antibody. And there is a third type called the Hayman nephritis. These will be repeated any number of times. I would like you people to kindly have this in mind. The mesangium, the capillaries again made up of endothelium and epithelium. And this is the basement membrane. Being one of the first topics, I shall be slow and deliberate. And this is the glomerulus. In the kidney, you have got the diseases such as those of the tubules, the interstitium, the blood vessels, and the glomeruli. And here I have got a picture of the glomerulus. What is the glomerulus? It is basically a tuft of capillaries. A tuft of capillaries that I am seeing. So this is the glomerulus. And surrounding these capillaries, there is a space called the Bowman's space, which is encapsulated by means of the Bowman's capsule. And these are the blood vessels and the ductules I will not be going into. Please remember only these things. The tuft of capillaries, the Bowman or the urinary space, and the Bowman's capsule. And this is just one capillary that I had shown. If you learn the small things properly, the big things will take care of themselves. So this is a capillary. This diagram you shall and will remember and draw. This is the epithelium. Epi means outside. And you find it has got multiple foot processes. So some books call them as podocytes also. And there are some window-like spaces which are the fenestrations. And the black color is the basement membrane. On the inner aspect, as mentioned earlier, we have got a capillary endothelium. So this is the basic structure of a single capillary, and the glomerulus is nothing but a tuft of capillaries. And they all have to be supported. We need a connective tissue matrix for it, that is the mesangial matrix. And there is a large cell called the mesangium, which forms part of it. So this is a very important diagram, ably explained by this author over here. I got the endothelium, then the endothelium, the epithelium, the basement membrane, and the mesangium. This is a more simplified diagram which I would like you people to draw. Give yourself a free hand. That's what it means. So again, I'm finding a tuft of capillaries over here. All the gray colors are all capillary outlines, and in the middle it is being supported by the mesangium. And as I had mentioned earlier, I have got some cell on the inner lining which is called the endothelium, and something that is outside, the epithelial cell or the podocyte. And these are all the fenestrations over here. This particular diagram you people should draw quite easily. And in this particular topic, it is a post-streptococcal glomerulonephritis. So remember EP for EP. So in post-streptococcal, there will be subepithelial deposits. Quite easy for us to remember. There are two basic syndromes in the glomeruli. One is called the nephritic syndrome. The glomerulonephritis post-streptococcal is mostly associated with this nephritic syndrome. It is an acute inflammation of the renal glomeruli, and there is a deposition of the immune complexes. This will be clinically characterized by hematuria, proteinuria, azotemia, oliguria, and hypertension. Any of this can be a history or a clinical presentation. Hematuria, proteinuria, azotemia, oliguria, and hypertension. Some of the terms I shall explain later. And this can happen in a few conditions such as a proliferative glomerulonephritis, in SLE, as well as polyarthritis nodosa. So this is a nephritic syndrome. Students, please be very careful. There is something called nephritic and there is something called nephrotic. And we usually interchange and write in the examination. What is the clinical presentation of this glomerulonephritis post-streptococcal? Generally, it occurs in children, 5 to 12 years of age. It can occur in adults also. And the classical history will be pharyngitis or a tonsillitis or a pyoderma. Sometimes the patient can be having scabies with superadded bacterial infection. And the latent period is given here. It varies from 1 to 2 weeks in pharyngitis and 3 to 6 weeks in pyoderma. One of the differential diagnoses is an IgA nephropathy. What it is, we shall see later. The causes for it, mainly it is streptococcal. That is why it is called as post-streptococcal glomerulonephritis. But then there are non-streptococcal causes also. Bacterial, staphylococci can cause this. Viral, hepatitis B virus or mumps. Fungal infections can all result in glomerulonephritis. Autoimmune disorders such as SLE and Goodpasture syndrome. And there can be some miscellaneous causes such as radiation. Please mention this because the list of differential diagnosis is mandatory for you to mention. So this is the classical sequence that happens. Commonly it is caused by group A beta hemolytic streptococci, and the serotypes commonly are 12, 4 and 1. There are many serotypes. These alone we shall remember. There are antibodies formed to the streptococcus such as anti-streptolysin O, and they are in the circulation. Because of this, there will be circulating immune complexes which are deposited. Where? Subepithelial. Subepithelial. So antigen antibody complexes are deposited in the basement membrane, mainly in the subepithelial region. Now, what is the gross picture? It is bilateral. Why? Because it is an immunological disease. An immunological disease is in the blood. All the organs can be affected and they will be bilateral, they will be symmetrical. Both the kidneys are affected to the same extent. The external surface is reddish brown and there can be fine punctate petechial hemorrhages. The gross features are not very specific, but please remember this: bilateral and symmetrical. A little complex, but let me see how easy I can make it for you. This is a diagrammatic representation of a normal glomerulus. As I mentioned earlier, these are the tuft of capillaries. And there is a large space surrounding it, the Bowman space or the urinary space. There is another type of epithelium over here, which is the parietal epithelium. This is normal. But compare this with this. So here, this is the glomerular outline, but it is being completely filled with cells. The space is hardly visible. And it is filled because of the proliferation of 1. The epithelial cell, 2. The endothelial cell, and 3. The mesangial cell. All are increased, so it is very easy for us to remember. Increase in the epithelial cell, endothelial cell, and the mesangial cell. And also, I am finding some irregular nuclei over here. There will be an infiltration with neutrophils. It is basically a glomerular pathology. We shall forget the tubules that are surrounding. So look at the difference between these, compare and explain. If it is difficult, again compare. So this is a normal glomerulus. This is the epithelium over here. The gray color is the basement membrane. Then the capillary endothelium. This is the mesangium. But here I find, as I told you, there is an increase in the number of epithelial cells, an increase in the number of endothelial cells, an increase in the number of the mesangial cells. Also, there is an infiltration with neutrophils. A beautiful diagram, very easy for you to draw. Please remember this. And as I had mentioned earlier, this is the epithelium again. The same diagram will be repeated any number of times. This violet color in this is the basement membrane, and beneath the epithelium, you find that there are subepithelial humps, which is basically the antigen antibody complex which is getting deposited in the subepithelial region. So when you study the light microscopy or any other microscopy, you find that there will be bumpy deposits. We call it as humpy bumpy deposits or the subepithelial deposits, which are seen in post-streptococcal glomerulonephritis. This we shall draw. Basically, though it is not part of it, I am trying to explain it. You find that this is the epithelium and this is the basement membrane, and all the round ones are the antigens. The antibodies are going and getting attached. So I find that there will be a uniform deposition. This is antiglomerular basement membrane antibodies. Sometimes I find that, look at this one. This is a blood actually, it's a capillary, and here in the blood there are antigen antibody complexes which are already formed. We call them as circulating antigen antibody complexes. They go and get deposited in the subepithelial region. So look at the two different types of depositions. And whatever it is, this particular diagram we shall remember. It is from your Robbins. So there is an antibody deposition. There can be the formation of the immune complexes which will activate the complement system. In the complements, two things alone we shall remember: C5a and C5b29. The C5b29 is a membrane attack complex which will lead to damage of the cells. And this happens to be a chemotactic factor, so there will be the attraction of the various cells such as neutrophils, mesangial cells, macrophages, and platelets, which will lead to the release of the various mediators, leading to a glomerular injury. So this particular diagram, I would like you people to practice any number of times because it is a common pathogenetic mechanism for glomerular injury. Many questions can be answered with this. What are the investigations in a case of streptococcal glomerulonephritis? When you do a urine analysis, there is a proteinuria. Proteinuria will be mild to moderate. Hematuria is conspicuous because there is a damage to the capillaries. There can be the casts. Casts of RBCs can be seen. And also you find RBCs can be individually present in the urine, more than 5 per high power field. And since it is an infection and complements are all getting used up, there will be hypocomplementinemia. That is, the blood will be having decreased amount of complements. And when you do a renal function test, there will be an increase in the blood urea as well as the serum creatinine, which means the kidney is getting affected. Usually there is a recovery, but in rare cases there can be a renal failure also. So these are the investigations. Let us remember them. These are the general investigations. And then what are the specific investigations? Anti-streptolysin O. So this particular antibody titer we should see. Similarly, there will be anti-hyaluronidase. The ASO titer is more than 12. And similarly, there can be another substance called anti-DNase B. So these are all specific for the post-streptococcal glomerulonephritis, and these are the general investigations which should be done. Please remember this, it will fetch you marks and it is important. And this is again an electron microscopic picture. This is the epithelial cell, this is the basement membrane, and in the subepithelial region there is a large deposit that is seen, antigen antibody complex. And this is a light microscopic picture. The tubules are all distended and they are filled with RBCs. This is what we call as a cast. Cast means it forms an outline of the entire tubule. So RBC cast can be seen. And there will be two types of these. In this condition, what will happen, since it is subepithelial, there will be a gap between the deposits. We call it as granular deposits. So here and there I will be finding the deposits. It is not uniform. In some conditions, it will be in the basement membrane, so there will be a uniform deposition of the complexes which are demonstrated by means of immunofluorescence. So what are all the investigations we can do? One is electron microscopy, two is immunofluorescence, and the third one is light microscopy. These three things we shall and will mention. The findings will be, there will be a gross hematuria, hypertension, there is a loss of the complements, persistent proteinuria, and there can be a microscopic hematuria also. In some patients, it is self-limited, whereas in others, it can get prolonged for a long time, resulting in a renal failure. So this will be the sequence of clinical features. As I had mentioned earlier, there are two syndromes. One is a nephritic syndrome. The classical history will be a young boy passing a cola-colored or a smoky urine. Proteinuria is there, but less than in nephrotic syndrome. And there will be a hematuria, which is not very common in nephrotic syndrome. There will be a hypertension, which is more prominent. Edema, of course, is present in both. The difference between a nephrotic syndrome and a nephritic syndrome, please do remember, you people can mention this as a differential diagnosis. And what can be the complications? Stupid mnemonic. Please remember H. There can be hypertensive encephalopathy, hypertensive heart failure, hypocalcemia, hyperphosphatemia, hyperkalemia, electrolyte imbalances can be there, hypocomplementemia, and how will the kidney function? There will be a renal failure. So remember the H. I hope you people are sharp enough to memorize this. So you had an abscess and now the urine is red. What is your finding? It is a post-streptococcal glomerulonephritis with S. TB.